Okay, good morning, everyone. I'm Dr. Jangalewski, or Dr. DZ, from the University of Florida. I'm the Chief of Head and Neck here, and today I'll be talking about oropharyngeal cancer and with a little bit of a focus on transoral surgery. So it's a bit of a primer for that. So hopefully this will be useful for all levels of residents from 1s to 5s. Some of the goals of the presentation are going to be to really understand the anatomy of the oropharynx inside and out. And then to apply an approach to a patient with oropharyngeal cancer. We'll look a little bit about the staging and the changes that have happened since January 1st, 2018. And then we'll talk about treatment options, decision-making, and then we'll focus on specifically on TORS and transoral surgery. So I'd like to put things in context first with a case. This is your typical oropharyngeal patient these days. The man in his 40s presents with a 2-month history of a sore throat radiating to his ear. So I normally would ask the junior residents, what's next? What do you do when you see this patient? So we're obviously going to do a history and a physical, and we want to make sure we ask about all the important symptoms of head and neck cancer: pain, numbness, taste disturbances, bleeding, trismus, dysphagia, airway symptoms, and so forth. And with a lot of patients these days, since HPV-related oropharyngeal cancers dominate oropharyngeal cancers, we don't see a lot of these typical symptoms. Sometimes patients may have just a neck mass, not uncommon for a male to come in and say that they found a lump in their neck while shaving, and that's their only symptom. That's very common. Other things they may complain about is a mild sore throat. As a tumor enlarges and it affects the glossopharyngeal nerve, then they may start getting some referred also not uncommon with larger tumors. Of course, some of the more ominous symptoms like dysphagia, airway compromise, or trismus happen with the later stage disease. So once we take a good thorough history, then we'll do a physical exam, and I always include the scope as part of that physical exam because it's really an extension of your examination. And while we're examining the patient, we really need to understand the anatomy that we're examining. So what is the oropharynx? Most of us know it as the back of the mouth, and we really need to know the boundaries of this. So if we look at a sagittal section, the superior boundary is going to be a plane right through the hard palate. And inferiorly, the plane is going to be at the base of the vallecula or the hyoid bone. And so inferiorly, it's the plane of the hyoid bone. Superiorly, it's hard palate. Anteriorly, we have the circumvalent papillae, the hard palate, soft palate junction, and the anterior tonsillar pillar. Posteriorly, it's posterior pharyngeal wall, and laterally, it's the lateral parts of the pharynx. So an exam question that often comes up is, what are the subsites of the oropharynx? So anatomically and from the AJCC cancer staging, these are the 5 main subsites. The tonsils or the lateral pharyngeal walls, the glossotonsillar sulcus, or the GTS as we often refer to it as, the base of the tongue, soft palate, and the posterior pharyngeal wall. Some people may also include the vallecula as a subsite, but that's it really depends on how much the epiglottis is involved, or the base of tongue, and that can be a bit of a judgment call depending on the patient. Another part of the oropharyngeal anatomy that's important to understand are the layers of the pharyngeal wall. These become very critical to understand when you're doing transoral surgery. So from inside out, we've got the mucosa, submucosa, the pharyngobasilar fascia, the constrictor muscles, and then on the other side of that, the buccopharyngeal fascia. And as you go further deep into the oropharynx, behind that, you'll get the parapharyngeal space, which we will go into more detail about. Another question I like to ask our residents is, what are the muscles of the soft palate and what innervates them? And so these would be the TVP, LVP, the palatoglossus, palatopharyngeus, and the uvulus muscle. And you'll notice that they're all innervated by the vagus nerve, the pharyngeal branch of it, except for TVP, which is innervated by V3. All right, knowing the anatomy, we also need to know, what does this anatomy do? So the oropharynx is critical in speech and swallowing. And another question that often comes up is, what are the phases of swallowing? So we have the oral preparatory, the oral, pharyngeal, and esophageal. The pharyngeal phase is triggered when the food bolus hits the plane of the anterior tonsillar pillars, and after that, it becomes a non-voluntary mechanism. What happens during the pharyngeal phase? This is also very important. All the anatomy that we have back there has to function in symphony, essentially. You've got a veal-pharyngeal closure, the elevation of the larynx. The larynx then needs to close with the epiglottis folding down and the vocal cords adducting. Then you have the contraction of the pharyngeal muscles, and then the base of tongue retracts like a piston and pushes the food bolus back into the pharynx as the cricopharyngeus opens and the food goes down into the esophagus. And all of that requires a lot of very complex nerve coordination and muscle coordination for that to happen. All right, so a little more about the anatomy here. As I said before, in order to do transoral surgery, we really need to understand this anatomy from inside and out. So we need to know our layers. So one thing, I apologize, this is a very nice diagram, but it's all in Latin terms, and there are a lot of words on here. So I'm going to try to highlight the important parts here. So first, one of the layers that you'll come through as you do a radical tonsillectomy, or as I call it, the PGY2 tonsillectomy, is the layers of the levator veli palatini muscle as you go superiorly. And then we have the palatopharyngeus muscle, which is further behind that, making up the posterior tonsillar pillar. And then anteriorly, it's the palatoglossus muscle, which is the anterior tonsillar pillar. And now if we look at a coronal view, or sorry, an axial view of the tonsil itself, you'll see here's the posterior tonsillar pillar made up by the palatopharyngeus muscle, anterior tonsillar pillar made up by the palatoglossus muscle, and behind all of this, we have the constrictors, the superior pharyngeal constrictor attaching to the buccopharyngeus muscle as well. The other thing I want to point out is, on the other side of all of this, we have a lot of important vascular structures. So here's the external carotid artery and all of its branches. And the important ones are going to be branches of the lingual artery, the facial artery, the ascending pharyngeal artery. And what protects these branches is going to be the styloglossus muscle. And we're going to go into that in more detail, but that is very important to know for transoral surgery. Now that you know your anatomy right side up, now you have to know it upside down. So we're going to look at some pictures of some upside down anatomy in a bit, but this is really important because this is the view that you see if you're using a robot, a headlight and bovie, or transoral laser surgery. Everything is upside down from the way you learned it. So here's some pictures from a nice study from Ohio State that looked at the anatomy that you encounter during transoral robotic surgery. So here's a good first example. This is looking at the oropharynx from you're doing a tonsillectomy, that type of view. You're looking straight in the patient's mouth. So in this case, the tonsil is gone. So you've got your anterior tonsillar pillar and your posterior tonsillar pillar, your base of tongue. Makes a nice little triangle there. And here's your uvula, posterior pharyngeal wall. And so that's the start of the first layer of anatomy that you need to know. Then as we go deeper, and especially with transoral surgery, one of the first things we do is we cut the superior constrictor muscle superiorly and get behind it into the parapharyngeal space here. And some of the things you'll notice is here's your anterior tonsillar pillar. The palatopharyngeus muscle is right here from the posterior tonsillar pillar. And some things that we need to be aware of are the styloglossus muscle. Here it says SMG. It's not the SMG. It's the styloglossus muscle. Deep to that is the stylohyoid. And in between those two, you'll have glossopharyngeal nerve. Here's your base of tongue. And we're going to go further here. And so these are really important to study on your own, really understand the structures, their relationships to one another, and the layers, what comes next after you go through one layer and then the next layer and the next layer. So if we look at the oropharynx musculature from the outside in, this is what we'll see. So we have our superior constrictor muscle attaching to the buccopharyngeal raphe here. And just deep to that is your styloglossus muscle. And as you can see here, when we're doing transoral surgery, we'll go into this in more detail, but you're going to cut this muscle out and take it out en bloc with the tumor. And usually your deep margin is going to be the styloglossus muscle here. Most of the time in early stage disease that's confined by the constrictor muscle, you don't need to take the styloglossus muscle with you. But if you're dealing with a more advanced tumor, this may come with you. And then you really need to be aware of what's deep to that, because that's where all of the dangerous structures are that you want to avoid. Another thing that we need to be aware of is all the blood supply that's in this area. So a few things that I'll point out here. I know this is from Netters. You probably have seen this from med school. A lot of different words here. Let's focus on a few that are important. So a lot of the blood supply is coming obviously from the external carotid artery. We have the ascending pharyngeal artery coming right up over the constrictor muscle. You've got the ascending palatine artery, which is a branch of which artery? The facial artery. And also coming off that, we have the tonsillar artery. And so all of these branches here create a very robust vascular network, many of which you may come across during transoral surgery. You may need to clip off or bovie extensively. And then I'll also add in here, we have the glossopharyngeal nerve. So we have this important muscle here. And which one is that? Styloglossus muscle, correct. And just deep and lateral to that, we have the glossopharyngeal nerve. Important to know about. It's not unusual to see that during a transoral operation. And usually you'll start getting a lot of stimulation of the muscles in the area when you're working around there. So very important to know this anatomy in here. All right, so back to some anatomical pictures that I want to highlight here. So looking at the upside down anatomy, here's another view. The constrictor muscle has been removed here. So now you see your styloglossus muscle. And here is the ninth nerve. And sometimes you'll see it kind of sitting almost right on top of the muscle, sometimes it's next to it, but you may actually see this not uncommonly. And then you'll notice the stylohyoid tendon next to that, which is going to be a little bit stiffer. And as you go down further here, you may actually feel something or notice something that's very hard. And that's going to be the greater cornea of your hyoid bone. Your middle constrictor muscle is a lot deeper to that. And then further deep to that is a big danger zone. That's where your internal carotid artery is going to be. And I'll show you a picture where that looks a little more obvious. Now, looking at the anatomy from the outside in, this is the view of, let's say, level 1B dissection. So here's your mandible. This is your submandibular gland. Here are your stylohyoid and posterior belly of digastric muscle. Which one is which? Stylohyoid goes up. Digastric goes back. That's important to know when you're doing a neck dissection. And if we retract that out of the way, we see here is hypoglossal nerve. And so what artery is this going to be next to it? Lingual artery. And then you have the styloglossus muscle. So now we know another structure that's in this area. So lingual artery is very close to styloglossus muscle. If you ever have to take the styloglossus muscle with you, one of the major sources of bleeding you can get into is the lingual artery, which you can usually control transorally with hemoclips. But sometimes you need to go into the neck to get that controlled. And if you're going to do a neck dissection anyways, you may be dealing with that sooner or later. And here's your glossopharyngeal nerve. So this is the view from outside in. All right, so a few more views here. This is just an extended view of what we've already seen. I'm going to leave this to you to study on your own. What I wanted to highlight here is here's your styloglossus muscle, and there's your lingual artery passing right underneath it. And this, I think, is the last set of these anatomical pictures. And what I wanted to highlight here was really the big danger zone. So stylohyoid tendon, if you're going this deep, you have to understand that the internal carotid artery is usually right in that area. So that's how deep you have to go to get it. As you go more superiorly towards soft palate, it gets more superficial. So you need to be aware of where you are at all times, because you can get into some major trouble there. And other things to note here, as you go deeper, here's your facial artery as well, coming into play underneath the styloglossus muscle. Just another view of the internal carotid artery to see its relationship to everything there. All right, so when you do radical tonsillectomy, when you're doing oropharyngeal cancer surgery, some structures that you need to be aware of are your superior constrictor and its relationship to the parapharyngeal space. You need to be aware of the external carotid artery and its branches, namely the facial and lingual arteries. Those are the big ones, but also ascending pharyngeal. You need to know the styloglossus muscle. That's kind of your safety net before you get into major trouble. Cranial nerve 9, you need to know its relationship to styloglossus. And the stylohyoid ligament, which is going to be a bit deeper and medial to those. And that is very important because if you cross that, you're starting to get close to internal carotid arteries. So these are very important structures to know about and to think about from an upside down, inside out view as you learn how to do oropharyngeal cancer surgery. Okay, so back to our patient. So now we understand the anatomy that we just examined, and our patient has a suspected cancer, and obviously one of the big questions is where did this come from? So historically, it used to be all smoking and drinking. But as the rates of smoking have gone down, the rates of HPV have gone up. So now the vast majority of oropharyngeal cancers are caused by human papillomavirus. There are some other risk factors that we don't often see in the US or in Canada. These are much less common. Things like syphilis, vitamin deficiency, poor nutrition, poor oral hygiene, exposure to radiation or radiation treatment, immunosuppression. These are all pretty rare, but just worthwhile knowing that they are risk factors as well. So what is HPV? HPV is a small non-enveloped DNA virus. And the way it causes cancer is it affects two oncogenes, E6 and E7. And E6, when activated by HPV, inactivates P53, which is a tumor suppressor gene. E7 inactivates retinoblastoma, which is a tumor suppressor gene. And it's thought that this can take years or decades to really develop into a cancer. Most people who develop an HPV-related oropharyngeal cancer are exposed to HPV usually in their 20s or 30s, but don't develop the cancer for 10 or 20 years. So it's thought that during that time, the body has eliminated the virus, and the damage caused by the virus has taken a long time to actually develop into a cancer. So how do we test for HPV? So the gold standard is a reverse transcriptase PCR of E6 and E7 mRNA. A good surrogate for this is the P16 immunohistochemistry. It's pretty quick, very cheap to do these days compared to what it was 10, 15 years ago, and it's almost 100% sensitivity. So if someone is P16 positive and they have the right history, they're most likely going to be HPV positive, and so we kind of use that interchangeably. HPV positive, P16 positive, same. So just to compare the two types of oropharyngeal cancer patients, we now know very well that we have two types of oropharyngeal cancer, HPV positive, HPV negative, and the patients have a very different demographic. So in HPV positive disease, the tumors are mainly in the tonsil and the base of tongue, so lymphoid type tissue. HPV negative, more commonly, it's still not as common, but there'll be more patients with soft palate tumors, posterior pharyngeal wall, and so forth. Those patients also tend to be older and more hardcore drinkers and tobacco users. HPV positive is more associated with riskier sexual behavior, and these patients tend to be more well off and have a higher education and socioeconomic status. P16 negative tumors also express a high level of EGFR, especially in smokers. And that's less common in the HPV positive cohort. Obviously, the survival is much better in the positive patients and not so good in the negative patients. One of the earlier studies on this from Maura Gillison's group really looked at these differences, and they found that overall about 3 years survival is 80 to 90% for HPV positive patients versus HPV negative, which is going to be like 40 to 60%. So survival rates are much different. And we can really stratify these patients on risk into low risk, intermediate, and high risk. So the first echelon of separation is going to be HPV positive versus HPV negative. Next is going to be their smoking history, and we kind of divide that at 10 pack years. So if we look at HPV positive patients, those with minimal smoking history have the lowest risk with a high rate of survival. Once they start smoking, then the next thing that we look at is their end disease. So depending on what their neck disease is, the worse it is, the lower their survival is going to be. And then as we go to HPV negative smokers, they have the worst survival. So this is kind of important to know how to stratify patients in terms of risk, prognosis, and when you're counseling patients on survival, this is often something that I get asked is, what's my prognosis going to be? How long am I going to survive? And this can help stratify these patients. All right, the histopathology of oropharyngeal cancers, as we all know, most of them are going to be squamous cell carcinoma, and there are a variety of different types of squamous cell carcinoma. So most of these are going to be poorly differentiated, often basaloid type for P16 positive. The P16 negative can be any of the just generic spindle cells, not uncommon. Verrucous and papillary, less common, especially in the heavy smokers. Other causes of oropharyngeal cancers, these are much less observed: lymphomas, minor salivary gland tumors, sarcomas, lymphoepithelioma, and those would kind of be the major differential diagnoses. The symptoms we mentioned, common things, especially as tumors get bigger. You're going to get endophagia, etiology, dysarthria, foreign body sensation, hemoptysis, weight loss. These are the more severe symptoms that we traditionally would see with oropharyngeal cancer. But as I mentioned, with HPV positive disease, it's often just a neck mass or a mild sensation of a soreness in the throat. They're usually not as pronounced as they are in the P16 negative cohort. So when you examine the patient, what are we going to see? Well, sometimes it's obvious. You may see an obvious mass, sometimes just asymmetric tonsils. Sometimes the tonsils look exactly the same, but when you palpate, the patient says, yeah, that hurts right there. If you ask them, do you feel it in your ear? They'll often say yes. If you rub it, sometimes you get a little bit of bleeding. It can be friable, and that can give you a clue of where the tumor is. Sometimes it's a base of tongue fullness, or the patient says, my voice sounds a little different. They kind of sound like they have a peritonsillar abscess, a little bit of a hot potato voice almost. And to really feel the base of tongue, sometimes you got to spray the patient with some lidocaine, which we're really trying to avoid during the COVID situation. So it's not always as easy to do a good bimanual exam, but you kind of need to do whatever you can in the clinic. And if you can't get a good exam, then you need to really take the patient to the OR for an exam under anesthesia. Okay, so back to our case. So this is what we see. So in this case, the mass is much more obvious. And some things we want to note here is the patient's mouth opening is very good. So trismus, not so much. We have great exposure. So this is good when we're thinking about, would this patient be a surgical candidate? Because if we're going to do transoral surgery, we need to be able to get in there to remove the tumor adequately. Some other things we want to note is how much of the soft palate is going to be involved, how much the base of tongue is going to be involved. Is this tumor mobile? Can you move it off the mandible, off the pterygoid muscles? These are all important questions to answer if you're going to consider the patient for surgery. And sometimes you can get a great exam in clinic, and sometimes the patient's gagged too much and you can't tell. If at all you're unsure if this patient's going to be a good surgical candidate, just take them to the OR and do an exam under anesthesia. You can even do a better biopsy if this has not been biopsied before. And you can get a really good idea as to how to counsel the patient on their treatment options after. All right, so now we've done a history, we've done a physical, we've talked about the, we've really explored the anatomy, we've talked about the risk factors, and now what we need to do is do some tests on the patient. So he's come in with really no tests, so what are we gonna do next? And so imaging and biopsy, correct. So first thing that a lot of us can get is a CT neck and chest. Depending on where you practice, some patients may already come in with this. Here at UF, we have a lot of patients traveling many hours to get here, so usually we can easily get this on the day of. Other options would be, some people really like using an MRI. I think that's very helpful when you're trying to plan surgery, so I may order that as well. A PET CT is often used at many institutions. I tend to use that sparingly because it often picks up a lot of incidentalomas that delay patients' care, and most of what we need to pick up is on the CT neck and chest. There's a study done a few years ago that showed that if the chest is negative in these patients, there's less than 1% chance of finding distant mets on a PET scan. So often a CT neck and chest is all you really need. Plus or minus pan endoscopy. Now, in a traditional P16 negative patient, this would often be very important. You look at the literature 40 years ago, and 5 to 15% of patients had second primaries synchronously. Now that number has really gone down. I can tell you in my experience, it's probably been about 1% that I've found on P16 negative patients. P16 positive patients, very unlikely, and there have been studies to show that it's almost zero chance that you're going to find a synchronous primary. So pan endoscopy is often not necessary to do in advance if you know what you're going to do for treatment. And then we want to do a biopsy. In most places, it's a reflex. You put an oropharynx on your order and you get the HPV testing. Sometimes you have to request it. So just make sure you know how your institution does this. All right, so our patient got a CT scan, and here's what we see. So we see a fairly well circumscribed mass. Looks like it's in the right tonsil. And some things to note here is the parapharyngeal space appears to be intact. Does not appear to be violated. There's a nice fat plane between the tumor and the pterygoid muscles, and the parapharyngeal fat space is also intact. Some other things to note are vascular structures. Here's our IJ, here's our carotid. They're well away from the tumor. And it doesn't look like it's invading the base of tongue, but that's often better assessed clinically than it is on an axial image. All right, so our patient was then biopsied, and we found that he has a P16 positive squamous cell carcinoma. So what's next? Staging. So we need to know what the patient's stage is. So staging is now divided by the P16 status. So we have P16 positive oropharynx, and this is something that you'll see over and over and over, and you'll memorize most of it through osmosis as you go through residency, but some of it you'll have to kind of just review and review right before your exams to make sure you get all the little parts of it. But some points to remember here is that the 2 to 4 rule, less than 2 is T1, 2 to 4 is T2, T3 is greater than 4 also. Remember that if it extends to the lingual surface of the epiglottis, it's going to be a T3. T4, it invades other structures. P16 negative, not much change here from the previous AJCC 7th edition. And it's very similar, but here we divided also into T4A and T4B, kind of based on resectability. And I put that in quotes because depending on who you talk to, that definition is different. Now, the other thing to know with P16 positive disease is that there are clinical stages for nodes and pathologic stages. So clinically, the things that have changed here is now you have N1, N2, N3. There's no N2A, B, and C. So N1, you're looking at ipsilateral nodes, less than 6 centimeters, and N2, contralateral or bilateral nodes, less than 6 centimeters. Greater than 6 centimeters would put you up to an N3. Now, pathologic staging, which is only available if you do surgery on the patient, is even simpler. It's just N0, N1, N2, and it depends on how many nodes positive you have. And you'll notice here that extranodal extension is not included. And then for P16 negative, the one thing that we really need to remember that's been added here is the extranodal extension. And so if you have extranodal extension, that automatically bumps you up to N3B. And so what this tells us is that P16 negative disease is very influenced by extranodal extension. If you have extranodal extension, your prognosis goes way down. For P16 positive, from the limited data we have so far, it doesn't look like it has as much of an effect on survival as it does in P16 negative disease. And then overall, the staging is a little bit different here. For example, an N1, T2 N1 is only a stage 1 instead of a stage 3 as it is in P16 negative disease. I won't go through all of these. This is something that you really need to just spend some time memorizing, but all the staging information is here. And you just have to remember that for Oropharynx P16 positive, you got clinical staging, you've got pathologic staging. There's differences. And then for P16 negative, the main things are now that you have included extranodal extension into the staging system. All right, so going back to our case, so let's do some staging on this guy. So he's got a right tonsil mass, greatest dimension is 3 centimeters. And when we measure that greatest dimension, it's the greatest dimension on either clinical exam or imaging. So you have to take your best examination, either one of those, and the highest number becomes the dimension. So 3 centimeters. He has a right neck node. That's 3.1 centimeters. So it's an ipsilateral node. And he was P16 positive. So in our old staging system, or if he was P16 negative, this would be a T2 N2A. However, if he's P16 positive, it's an N1. And so the overall stage, the prognosis, there's a big difference. P16 negative, this is a stage 4, P16 positive, stage 1. All right, so what's our treatment for this patient? Okay, so first thing for all these patients is preventative. If they're a smoker, we need to counsel them on tobacco cessation. If they're consuming a lot of alcohol, we need to counsel them on alcohol cessation, but in a safe manner. Not something that they would want to stop cold turkey. They may need to go into a program for alcohol cessation. And then we need to think about primary treatment. We think about the primary site and the neck, and adjuvant treatment. Are they going to need adjuvant treatment? And something that can help you is the NCCN guidelines. One of the big things, this is kind of now old hat, but one of the big things that changed a few years ago was dividing the patients to HPV positive and negative. And then as we go through the NCCN guidelines, you know, as we all know, we have really 3 cancer treatment modalities: surgery, radiation, chemo, combinations of the 3. It's either primary surgery or primary radiation usually that we're going to start with. And you can look at these algorithms. These can be very helpful if you're deciding on how to treat a patient. You don't necessarily deal with this on a daily basis. But for P16 positive disease, you start off looking at the T stage, T1, T2, and the first section here is N0. So here you have an option of doing primary surgery or definitive radiation. Ideally, you want to try to pick the patients that are going to need the least amount of treatment as possible with the same survival. And a lot of the data shows that the survival is almost identical for primary radiation or primary surgery. So we want to figure out the best treatment for every particular patient, and each patient's going to be a little different. So we want to minimize morbidity, maximize survival. And so we have options of primary surgery or primary radiation. As we look at T1 to T2 and 1, it's going to be similar options. And the nice thing here is you can follow this along. You do a resection, you get your final path. There's no adverse features. You don't need any adjuvant treatment. If there are adverse features like external extension or a positive margin, you may need to re-excise the margin. If there's external extension, then you're thinking about adding radiation plus or minus chemo and so forth. And as you go through more advanced disease, the options are going to require more adjuvant treatment. So in general, when you're looking at early stage disease, and we start by looking at the T stage, ideally you want to look at single modality treatment. So a lot of these patients may only need radiation or just surgery. T3, T4, you're looking at dual modality almost every time. So chemo-RT or surgery plus RT. And ideally we want to avoid triple modality in P16 positive patients. We know that in P16 positive patients, triple modality doesn't really improve survival. So if a patient is going to need chemo-RT after surgery, a lot of the time they're probably going to be better off with a de-escalated protocol of chemo-RT up front and avoiding the surgery. Now, if you can do surgery and there's a good chance that they won't need RT afterwards, then you're probably better off with surgery in many cases. But it's a case-by-case basis, and that's why treating these patients is very important to do in a multidisciplinary setting. If you have colleagues in radiation oncology, medical oncology, who you can meet with on a weekly basis for a tumor board, that's going to give your patients best outcomes. And there's good data to support that you cannot treat these patients in a silo. It's a team effort to give them their best possible outcomes. Other things to consider: N0 or N1. Often single modality is going to be enough. Radiation or surgery have similar outcomes. So if a patient has an N1 on pathology and that's their only possible indication for adjuvant treatment, you may elect not to do the adjuvant treatment. And the important thing to remember here is that the neck dissection often has a benefit of staging info. A lot of the time, a supposed N0 patient on imaging and clinical exam may actually be found to have nodal disease, which may indicate that they need more treatment, or they may not, but it has good prognostic information. As you go up in the end staging, dual modality becomes more used and more important for maximizing survival. Some other things to consider is how are you going to treat the neck? A lot of the time you can get away with ipsilateral treatment with a smaller tonsil cancer. Now a lot of people are starting to advocate that for well lateralized small tongue-based lesions. But in general, we know that the base of tongue, soft palate, and posterior pharyngeal wall tend to have bilateral lymphatic drainage. And so those you need to consider bilateral treatment on. T4 lesions, same thing. There's good evidence to show they tend to have more bilateral drainage. And T2 and above disease. So those are ones you would want to consider bilateral treatment. And the other thing they need to remember is Oropharynx also drains the retropharyngeal node. So that's something to consider in your treatment and something to look at on your imaging. Sometimes a positive node can be resected with the primary. Other times it may need radiation treatment. As the disease stage goes up, a lot of times the retropharyngeal nodes are included in the radiation plan. And when do we give radiation treatment? Well, it's usually going to be 4 to 6 weeks post-operatively, ideally. And the thing to remember is if you're doing transoral surgery without reconstruction, you need to make sure your patient is healed enough. If they start radiation, they haven't healed completely, you're at a much higher risk of mucosal necrosis, which can cause things as bad as a carotid blowout, very long-term healing problems, a need for a long-term G-tube. You can even get inflammation of the prevertebral space and even an epidural abscess if you get an infection in that area. So you just have to be very careful in planning with your radiation oncologist when to start the radiation. And what I usually do is I have these patients see me right before 2 weeks before their plan to start radiation, make sure they've healed, and they haven't, we'll delay the radiation by a little bit longer. The dose, now this is very institution dependent. The guidelines give you a range of 44 to 60 gray if your margins are negative. And if the margins are positive, they recommend 66 to 72 gray. Now with P16 positive disease, there is a lot of variability depending on where you practice. A lot of places are de-escalating these patients, whether they're on a protocol or not. So there's a lot of heterogeneity in how patients are treated. So it's just something to keep in mind. The guidelines give you a good range to go with, but this is really something to discuss with your radiation oncologist and come up with individualized plans. So what are your indications for post-op chemo-RT? So based on the RTOG and EORTC studies from years ago, the two main indications that were the same both studies that improved survival were positive margins and extracapsular spread. This is when you would add chemo to the RT. And depending on the patient, this improves survival by anywhere from 4 to 16%, on average about 8% improved survival. Now indications for post-op RT, or the things that are called adverse features by the guidelines, are going to be advanced T-stage. And the T3 is a more soft indication. Not everybody uses that. If that was your only indication, some people may omit the adjuvant treatment. Advanced neck disease, perineal invasion, lymphovascular invasion. Now, that one is also another soft indication. If that's your only indication for RT, which is rare, but it happens, some people may say we're not even going to use that as an indication because it's a more softer indication. Extracapsular spread, or extranodal extension as we call it now. And then nodes that are lower down in the neck, level 4 or level 5. And even some people will include in here 4 or more positive nodes as an adverse feature. And that one sometimes many people will include chemotherapy for. Other important things to think about on your pathology report are the margins. So traditionally, especially for P16 negative disease, we want to see a 5 millimeter tumor-free margin on the specimen on pathology. So when you're cutting out the tumor, you're usually aiming for a 1 to 2 centimeter visual and palpable surgical margin in order to get that 5 millimeter margin. And the reason for that is that the tissue tends to shrink at least 30% in the formalin, depending on how it's prepared or how your pathologist measures the margin. So you need to be very aggressive, especially in P16 negative disease. On P16 positive, usually a 1 centimeter margin is going to be enough. And always remember, if you're using a flap or you're reconstructing a tumor, don't skimp on your margins. In fact, try not to ever skimp on your margins because you want to maximize your patient's survival. And so I put in here, what about P16 positive disease? What's considered a negative margin or not even a close margin? Well, that depends. There are a few different trials. The Pathos trial uses a 5 millimeter margin. The 3311 uses a 3 millimeter margin. Weinstein's early papers from like 2007, 2009, 2010 used a 2 millimeter margin. A lot of people are now saying no ink on the, no tumor at the ink of the specimen is good enough. And that we're starting to think that the constrictor muscle itself may act as a barrier to spread. If the tumor hasn't breached that constrictor, that may be enough for a negative margin. However, once it goes past that constrictor, now you're into the parapharyngeal fat. It's like the tumor has no barrier to spread. And that may, and in those situations, getting a negative margin is much more difficult. But the bottom line here is we don't all agree on what a negative margin is yet. We need some more evidence for that. So this is going to be really institution dependent and something to discuss with your multidisciplinary tumor board. So some approaches for surgery. We have our newer approaches tend to be transoral. And honestly, a lot of these aren't new. TORS is just a newer tool to do the same thing that we used to be able to do with the bovine headlight. If you look at the French literature from about 20 years ago, they were doing this back then for smaller oropharyngeal cancers, but they just put on bovine headlight, just like they would do a tonsillectomy. And in many cases, you don't need a robot because you can do exactly what the robot's doing just that way. Where the robot comes in handy is the glossal tonsor sulcus, the base of tongue, for teaching purposes. And so there are some advantages to it, but there are times where you can get away without it. And another great tool that does a very similar thing is transoral laser microsurgery. This can give you really good access to tight places like the glossal tonsor sulcus and the base of tongue. And it's just a matter of preference. Do you like using a bovine headlight? Do you like a robot? Do you like the laser? The results are about the same. It just depends on what gives you the best results in your hands. Other approaches, the oral approaches, the open approaches that you need to be aware of are the transpharyngeal approaches and the transmandibular approaches. And these I tend to hardly ever use for primary oropharyngeal cancers. They're more used for if the patient has really bad trismus, if they've failed radiation treatment before. In those cases, a lot of time TORS doesn't offer a huge advantage, at least where I practice. And it depends where you practice and how much radiation patients are given. If a patient gets 70 or 74 grade to the oropharynx, the robot's not that helpful. You really need to open things up and get in there to stay safe because you're going through very scarred planes. If a patient's getting lower doses of radiation, robot might be more useful for you. So just a little bit here, you can study this on your own. I'm not going to go into tons of details about these, but just be aware there's the transpharyngeal approach and some good pictures from the old Baileys are here. And so the way you do this is you're basically dividing the suprahyoid muscles, kind of like you would when you're entering the pharynx on a laryngectomy. And the structures you need to be aware of are the lingual arteries. So you don't want to indiscriminately bovie through this area and go through both and compromise the blood supply to the tongue. But as long as you're aware of those, this is a very safe way to get into the pharynx, just like you would with laryngectomy. And you can get to the posterior pharyngeal wall here for smaller tumors. You can get to the base of tongue. You can close a lot of this primarily. You can put a flap in there, bring it through here. A lot of different things you can do. A lot of, this does offer you very good access to the vallecula, base of tongue, posterior pharyngeal wall. Here's just another example of a base of tongue tumor being accessed the same way. And another way to do this is going laterally, where you would divide mylohyoid muscle, hyoglossus muscle, kind of getting in there through level 1B. Something to be aware of is the hypoglossal nerve right here, the superior laryngeal nerve. This is another approach. Another approach that's, I think I've maybe used once is the Trotter procedure. It's for a midline, small midline base of tongue tumor. Split the tongue in the middle, cut the tumor out, sew it back together. Very nice approach, very rarely used. Transmandibular approach, in my training we use this pretty much for every case. Now it's used a lot less frequently, but still very useful in patients who have trismus or who have a large posterior oral tumor or oropharyngeal tumor that you need to remove, especially after radiation treatment. this probably gives you the best exposure. There are ways to do this. You can split the lip or not split the lip, but for the maximum exposure, you need to split the lip, split the mandible, do a circumlingual incision, leaving enough mucosa to sew to on the mandible, kind of like in a trauma case. And things to remember here is that you have two major structures at risk, the lingual and hypoglossal nerves, which sometimes you need to divide to maximize your exposure. And if you can keep a lingual and hypoglossal nerve at least one on either side, that'll maximize your functional outcomes. And things you can do with these is divide them, tag them, and then reapproximate them at the end of the case, or use a cable graft to fix them if necessary. So the way this looks is you can make your incision here, and this is one approach. I personally like using a stair-step osteotomy. Some people take out a tooth to do that. I like to do it between tooth roots if possible. And this way, this actually lines up the mandible very nicely afterwards. You can plate it and pre-plate it or plate it afterwards. Make sure the patient's in occlusion before you're done. And here's your circumlingual incision. Then you get to your tumor, measure out your 1 to 2 centimeter margin. I like 2 centimeters personally or more. And then measure that out, do your resection, send your margins, put your flap in, close things up. So those are the approaches here. And then once you've made your defect, you need to think about how are you going to reconstruct the patient. And in many small cancers, especially if you're using a transoral approach, the idea is to let them heal by secondary intention. You could use some local flaps, such as a facial artery myomucosal flap. So FAM flap is an option. In some cases, you could use a palatal island flap. A submental flap is an option. So these are some local options. As you get bigger tumors and bigger defects, sometimes your optimal functional outcomes are going to be the free flap. And usually the workhorse for this would be the radial form free flap. In thinner patients, and ALT is great. Some people really like using the ALT and thinning it out even in thick patients. It's also a good option. Just depends what's going to give you the best outcome in your hands. Old school options would be a pec flap, or even a lat flap, or temporalis flap, all of which are pedicled flaps, but they all have their drawbacks with scar contracture, trismus, and worse functional outcomes for a variety of reasons. But certainly all good options if you don't have a free flap, or if you're practicing somewhere where that's not an option. All right, so now we're going to focus a little bit on transoral surgery to end this talk. And I'm just kind of leaving it vague as transoral surgery because this applies to whether you're using robot, laser, or a bovine headlight. And the idea of transoral surgery is we want to achieve a gross total resection with negative margins. How you define that negative margin is going to be dependent on your institution. And that's really for P16 positive disease. For P16 negative, you just want to get as close to 5 millimeters or more as possible. And ideally, especially with P16 positive disease, we want to avoid triple modality therapy. So we want to select the patients that are less likely to need chemo-RT after surgery. And we want to figure out who's going to be a good candidate for TORS. So let's first figure out who's not a good candidate. So some things we need to evaluate on their preoperative imaging: vascular factors. Is there a retropharyngeal internal carotid artery? Is that artery close by to where you need to make your cuts? Are you going to expose it when you're done your resection? Those are all very important things to think about. Based on cancers, is it close to the midline? Are both lingual arteries going to be at risk? Is a tumor adjacent to the carotid artery? Is it encasing the carotid artery? All very ominous things that you want to avoid doing TORS in. Other things to think about is what's your function going to be like afterwards? So sure, you can cut out the whole base of tongue, but if you cut out more than 50% of the base of tongue, plus or minus some of the epiglottis, and you don't reconstruct it, swallowing outcomes are going to be dismal. If you're going to need to take out more than 50% of the soft palate, swallowing outcomes are going to be dismal, especially if you don't reconstruct it. If you do reconstruct it, different story, but if you don't, not so good. If you need to take out more than 50% of the posterior pharyngeal wall, you're going to lose a lot of that constrictor contraction. That's another problem. So these are things to think about where other treatment modalities might be a better long-term functional outcome for the patient. Oncologic factors, T4B tumors. As we mentioned before, when you're examining the patient, is the tumor fixed to something like the mandible or the prevertebral fascia? On imaging, does the tumor violate the constrictor muscles? If it's spilled out into the parapharyngeal space, chances are you're going to need chemo-RT. Maybe that'll be a better option than going with surgery. Trismus, are you going to be able to get a robot in there? Or are you going to need to do a big open approach? Does the patient have METs, unresectable neck disease? Some obvious things also to think about. Medical and anatomic factors. Is the patient on anticoagulative therapy that cannot be stopped? I put this as a relative contraindication because you could potentially put a free flap in there and cover the structures that are exposed, and you can carry on with fairly low risk. Does the patient have C-spine disease, i.e. are they going to be able to extend their neck? Or is their C-spine unstable where you just can't extend it because you're going to potentially paralyze the patient? So other things to think about as well. And then we have to think about exposure, because one of the biggest things about transoral surgery is seeing what you need to see. So we're going to talk about I think it's 7 T's. We're going to go through them here. 8 T's, pardon me. So things to think about. Teeth. Do they have big buck teeth? Do they have big incisors or canines that are going to get in the way of your Crow-Davis or your FK retractor? Does the patient have trismus? What's their transverse mandibular dimension? So if they have a very narrow mandible, your mouth gag is going to get in the way. It's going to smack into the teeth. You're going to have a hard time getting exposure, especially the base of tongue. Do they have mandibular or palatine tori? Another thing that's going to limit your exposure. Do they have a huge, massive tongue? Sometimes that really limits what you can see. And so examining them in clinic, if you can't really see the tumor, or they have like a Mound Patty 4 in clinic, that may not be a good option for transoral surgery. Tilt, how much can they tilt their head? Can they extend appropriately? Treatment, have they had prior radiation treatment? How much of it have they had? Does their oropharynx and neck feel like a block of wood? That's when you want to start thinking about, is transoral surgery going to offer me a big advantage here? Or how am I going to approach this? Do I need to think about reconstruction? Some other things to think about, because there's a lot more at play with the radiated oropharynx and neck. And then lastly, the tumor. Is tumor fixed? How big is it? Is it spilling into the parapharyngeal space? So this is a good checklist to go through as you're thinking about, should I consider transoral surgery? So some examples here of imaging beforehand. So is this a good choice for transoral surgery? So here I've included the pictures of this from a good study from Toronto. Some good imaging using the MRI that will help you delineate whether or not the patient's going to be at risk for needing chemo-RT afterwards. So this specific example, here's our tonsil tumor, and we're having a hard time seeing the parapharyngeal space. And here there's actually some fat still in the parapharyngeal space. So this one is showing that this actually is a fairly limited tumor, and this one actually may be a very good option for transoral surgery. However, here we have some other problems. This is a patient whose parapharyngeal space totally obliterated, and that's not going to be a good choice for transoral surgery, because here you're going to, the chance you get leaving a positive margin is very high, so they're probably going to need chemo-RT afterwards. And if this is P16 positive disease, your outcome's not going to be very good with triple modality compared to just chemo-RT. And so here's another option of the tumor invading parapharyngeal space. Another one that may be a better option for non-surgical modalities. Same thing here. Other things to consider is the tumor invading the parapharyngeal space? Is it invading the nasopharynx? How much of the soft palate is it invading? So here are some other options where, similar to the previous case, you may want to avoid approaching this with surgery. Base of tongue, which ones are good? Well, typically for transoral surgery, we're going to look for limited ones that are really limited to the lymphoid tissue. Lateralized ones are good. As I mentioned before, once you start crossing midline, you're putting the vasculature of the tongue at risk, and also very poor functional outcomes if you have to take a huge chunk of the base of tongue on both sides, more than 50%. And here we want to watch for the deep extension. Sometimes the tumor is more than you anticipate it to be. So a good example here is this tumor is going a lot more anteriorly. So sometimes you'll notice the tongue feels soft and it's mobile. The tumor's at the base of tongue, and then when you scan them, you notice it's gone all the way anteriorly. And in order to resect this, you're going to do a total glossectomy or a total glossectomy and laryngectomy to get negative margins. And with P16 positive disease, you're much better off doing chemo-RT in a situation like this. So these are good examples of how you really need to individualize treatment. Some other things to consider would be your carotid artery. Is it encased? Do you have a retropharyngeal node like the middle picture does here? And what does your nodal disease in the neck look like? If it's already invading adjacent structures and it's fixed and it's obvious that it has ECS, well, especially in P16 positive disease, you need to keep that in mind that you may be adding chemo-RT after surgery. All right, so some things to think about in your imaging checklist are the parapharyngeal space, the vasculature, the nodes, think about your retropharyngeal nodes, and what your tumor margins are going to be. And so lastly, the last section, I just wanted to go through what is a radical tonsillectomy? What's the theory behind this, the anatomy? What exactly are you trying to accomplish? So these are some good pictures from a paper from Chris Holsinger, who's at Stanford. This was a group that he worked with in France. And this really shows you what you're trying to accomplish here. So the ideal resection is going to be an en bloc resection of the whole tonsillar fossa, including your posterior tonsillar pillar, anterior tonsillar pillar, and the constrictor muscle all the way here. As we remember from before, we've got our styloglossus muscle. This is our friend that protects us from all the bad things. So here you're going to have the external carotid artery and all of its branches. And here's the 9th nerve right there. So the first arrow points to styloglossus, second one is the external carotid artery and its branches, and then the third one here is the 9th nerve. Back here is going to be your internal carotid artery and the IJ if you go really deep. And so as we look here, these are our muscular layers that we're going to be thinking about: anterior tonsillar pillar, or the palatoglossus muscle, the constrictor, palatopharyngeus muscle is number 5. One of the first things we do is we make a cut superiorly through the soft palate, and then we enter the parapharyngeal space by dividing the constrictor muscle and getting between it and the medial pterygoid muscle. Here's the parapharyngeal fat. And then we carry on inferiorly. As you can see that we're kind of unhinging that area and exposing that fat. As we go further down here, now we're thinking about, here's palatoglossus, our friend that hopefully we don't need to take. We can use it as a margin. We can use it as a safety net, because the lingual artery is going to be down there, 9th nerve is going to be down there, facial artery is going to be down there, and the deeper you go, the closer you're going to get to the internal carotid artery. And at the very end, we're detaching this. Sometimes we're taking a cuff or base of tongue, sometimes we're below that, so this is the inferior aspect of the lateral pharyngeal wall, and then we come up the posterior pharyngeal wall to finish our resection. And something we need to think about is, what adjunctive procedures should we do? So obviously, neck dissection is most likely going to be done either before or after this, either the same day or a different day. But another thing we need to think about is prophylactically ligating the vessels supplying the tumor bed that we just resected, especially if we're leaving it to granulate on its own. Now, if we put a free flap in there or another reconstructive tissue, then we don't need to do this. But if we're leaving this thing open, it's been shown that ligating the lingual artery, ascending pharyngeal, facial artery, or the external carotid artery itself definitely decreases life-threatening hemorrhage. It doesn't decrease the bleeding rate necessarily, but it decreases severe and life-threatening events of bleeding. And so that's kind of become the standard of care in these patients. But the thing to remember is, you decrease the blood supply, you slow down healing, make sure you reassess the patient before they start radiation to make sure they're healed, because one of the things that you can see is mucosal necrosis if you start radiation too early. So I mentioned the neck dissection already, and you know, the future of this is really going to be de-escalation. When can we not add any adjuvant treatment? When can we limit the postoperative radiation treatment? When can we limit chemo? And we're already seeing a lot of evidence that external extension doesn't have the same role in P16 positive disease as it does in P16 negative disease, and many people are stopping chemo for that indication. There are a lot of trials going on using immunotherapy, omitting radiation, radiation only with low doses, no chemo, and so forth. So a lot of controversies with this right now, a lot of heterogeneous protocols. So just be aware that this is an area that's continuing to evolve, and we really need to individualize treatment and make sure that we approach these patients in a team approach. All right, and that is the talk. Thank you very much for your attention, and I appreciate this opportunity. All right, Sarah Lynn, I am done. I don't know if you can hear me.
Okay, thank you very much. That was great. We actually have a handful of people that are listening right now. So.
Oh, great.
Yeah.
Excellent. Hopefully they found it useful.
Oh, absolutely.
All right. Well, if anyone has questions, they can email me, or I'll send you the slides so that people have access to them.
Okay. Thank you so much. We appreciate your time and being here.
Of course. Thank you so much. Take care.